So it looks like many people have found their way to the food. That's usually the best draw. I'm Richard V., Chair of the Department. I'm happy today that we're having one of our very special annual lectures. And I'm going to introduce Joan Romano, who's a professor and the director of our psychology internship program, who will do the introductions for us. Thank you.
Thank you, Richard, and thank you all for coming today. We're very pleased and honored to have Dr. David Takeuchi of the University of Washington School of Social Work present the Shigetomi Memorial Lecture for 2011. And before I introduce Dr. Takeuchi, I'd like to say a few words about Carol Shigetomi and the fund that was established in her name that supports this lecture series. Carol completed her psychology internship training in our program here at the Department of Psychiatry and Behavioral Sciences in 1982, and then went on to a postdoctoral fellowship. But unfortunately, she was killed in a tragic accident in 1984. And her family established a fund through the psychology internship program to honor her life and achievements. And we continue that tradition today with this lecture. Carol graduated from Pomona College in Claremont, California with her bachelor's degree in psychology. And she then attended the University of Utah Clinical and Developmental Psychology doctoral program with a special interest in children and families. She came to our psychology internship, as I said, in 1982, and distinguished herself as an excellent clinician, young professional, and all-around wonderful person during her rotations at Children's Hospital and the Center for Human Health and Development. She impressed all who worked with her as a bright and caring woman with many talents and gifts for working with children and families. Among her talents were painting, weaving, and music, and she had a passion for the outdoors. She loved to hike, exploring the canyonlands in Utah as well as the Northwest. And she was on one of these hikes in the Columbia River Gorge on the Eagle Creek Trail in January of 1984 when, as the group she was with was trying to traverse a very icy portion of the trail, she fell, unfortunately, and slipped to her death. In the aftermath of her death, her family generously endowed a fund to honor her spirit of giving and to establish this memorial lectureship in her honor. And we've been privileged over the years since 1985 to have brought in many eminent speakers on a wide variety of topics, particularly those related to multicultural issues and to child psychology, as a result of the generosity of the Shigetomi family. Unfortunately, they can't be with us here today. Carol's father has passed away, and her mother is unfortunately not in good health, but their gift carries forward and allows us to celebrate Carol's memory and their generosity. So this year, we are very honored to have Dr. David T. Takeuchi as our Shigetomi Memorial Lecturer. Dr. Takeuchi is a sociologist, and he holds the position of professor in the School of Social Work and the Department of Sociology at the University of Washington. He is also the Associate Dean for Research in the School of Social Work. He has postdoctoral training in epidemiology and health services research, and his research focuses on investigating the social, structural, and cultural contexts that are associated with different health outcomes, especially among racial and ethnic minorities. He also examines the use of health services in different ethnic communities. He has published in a wide range of journals, including the American Journal of Psychiatry, the American Journal of Public Health, Archives of General Psychiatry, Journal of Community Psychology, Health and Social Behavior, and Social Forces. In addition to his scholarly work, he has worked with a number of national and community organizations. He has received the Legacy Award from the Family Research Consortium and the Innovations Award from the National Center on Health and Health Disparities for his research contributions. Most recently, he was honored with the University of Washington 2011 Marcia Landolt Distinguished Mentor Award. His research provides a critical perspective on the study of mental health services for ethnic communities, particularly the Asian American community. So we are extremely pleased to have Dr. Takeuchi speak today on the topic of access to and quality of mental health care in Asian American communities, a review and critique. Dr. Takeuchi.
Just bringing the slides up here, hopefully. Oh, thank you.
Well, thank you so much, Joan. Is this on? Oh, I'm sorry. Thank you so much, Joan. It's, if I were a wise man after the introduction, I would just stop and ask for questions. But I appreciate the comments, and I really appreciate being part of this lecture series, hearing about Carol and her background. I think I can only aspire to have those kind of qualities that she has. So thank you very much. Just admission beforehand, I have strived over the years to combat negative stereotypes or harmful stereotypes. So I'm going to fumble a lot with the computer here, and that's to demonstrate that not all Asian Americans are good with the computers. We're in an intimate setting here, so I thought I'd begin with showing you some family members, and I think they'll serve as a metaphor for some of my talk today. So, let me just, like I said, this is a 4-year-old dog that we have. It's a Bichon Frise. When we got him, my wife took the first 2 letters of my first and last name and combined them and called him Data. And she said I would then have a legitimate excuse to stay home and say I'm playing with my data, working with my data. And so I kind of thought of different angles, and naturally with a dog you have to walk the dog, and I've learned that you actually collect after data too. So I actually told parts of this anecdote at a conference with graduate students, and after the talk, this graduate student came up to me really in this heightened state of anxiety and said, "Excuse me, but you just have 1 dog, shouldn't it be Datum?" I told her to get a life. Now in November, we got another dog, and this is now he's about 6 months old, and my wife, because she has this wicked sense of humor, named him Theory. And the idea is that since data has grown quite large, she said it really matches my research because it's big data, little theory. And I just wanted to use that as part of the metaphor about how we look at a lot of research in ethnic minority communities. I think over time there is an emerging stock of data out there, but we don't really have a lot of great theories in looking at it, and I'll refer to this as I go through the talk. Before I go on, I just want to acknowledge some of the grants that help put some of the data together, as well as some of the thoughts behind this talk, and then the Catherine Hall Scholars Award through the School of Social Work. One of the things that is one of the buzzwords in today's research world is translation research. And I think when you look at ethnic minority communities, especially for Asian Americans, they can be not seen in much of the research literature, and I call it being lost in translation. So I want to bring up 2 major findings that have been critical in developing interventions in Asian American communities. And that is, Asian Americans often do not have access or do not access mental health services compared to some other racial ethnic groups. And when they do seek out services, they're less likely than some groups to receive quality care. In fact, when I have participated in writing chapters over the past couple years, this finding is certainly one of the conclusions that we come in our chapter. But actually, these findings really come if you look at the literature and some of the publications in the 1970s, these are two of the consistent findings that we have. In fact, Stan Su and Herb McKinney, who are actually at the University of Washington and I think worked with psychologists and psychiatry, did their critical commentary and paper making known about not only Asian Americans but most racial ethnic minorities often did not access mental health services, nor did they receive quality care. So over this 40-year period, and this is part of the punchline, is that we really haven't changed the findings for Asian Americans and for the rest of other racial ethnic minorities. Let me just run through to provide a context about how Asian Americans have been viewed over the course of history, especially when looking at some of the health data. And in the late 1800s and the beginning of the 20th century, Asian Americans at that time were referred to as Orientals to mark how different they were from other populations, how exotic, and in part to say that they were not necessarily part of the mainstream. And at the time, biological and genetic kinds of frameworks were used to showcase what might explain why Asian Americans were different from other racial ethnic minority groups. And at that time, it was also used to showcase why Asian Americans might be, at that time, overrepresented in some state hospitals. Over time, especially in the 60s and 70s, there was a concerted effort among policymakers and activists and researchers to transform this Oriental stereotype into a category that was both unifying and that could separate this distinction of Orientals being, quote, deviant or not normal, and that was the Asian American category. So Asian Americans then became this large category to refer to all the immigrants and U.S.-born people who came from Asian countries as a way to unify Asian Americans, as well as to highlight the last part of that category, which is the Americans. So it's an attempt to bring in Asian Americans into the U.S. mainstream. In the 70s, 80s, and even continue today, not only have Asian Americans been thought of as part of the American landscape, but it's also been held up as the model minority. It's part of the, I guess, overcompensation of Asian Americans, the Asian American category. That is, Asian Americans were seen as the middlemen between whites and other racial minorities, especially Black Americans, to highlight that they, in fact, have succeeded despite all the stresses and attempts to exclude them over time. In the 80s and 90s, there was an attempt to resist the myth, and if you look at the literature during this period, it's always this back and forth about Asian American researchers making the attempt to say why they're not a model minority and to advocate for more research and more services within Asian American communities. And often, because this model minority stereotype can be so insidious, we can be trapped by the myth. So it becomes this constant debate around this myth without truly exploring other facets of Asian American communities that may be more pressing to resolve. One of the things that we're moving is to go beyond looking at ethnic differences within Asian Americans and to explore more the heterogeneity that exists within Asian American communities. And that leads to the current thinking about looking at intersections within Asian American communities. The Brits call it super diversity, where you're not just looking at race and ethnicity, but you're looking at how different facets of minority communities may help to explain different phenomena. And one way to capture that heterogeneity is to see all the complexities within Asian American or different racial and ethnic minority communities, and to try to understand how these different facets of the communities may help to explain different health problems. I want to, in providing this context, I want to then use some data from the National Latino and Asian American Study to showcase some of the findings around Asian American and mental health. The National Latino and Asian American Study was the first study combining Latinos and Asian Americans using the same design and sampling strategies across the nation. And it was to estimate the prevalence of disorders for Latino and Asian American populations, try to understand the correlates, and compare the results to other national studies. The NSAL was a similar epidemiological study of Black Americans done by James Jackson and his group at the University of Michigan. It had a sample of about 5,000 respondents. And a national comorbidity study replication. Principal investigator was Ron Kessler, who was then at Michigan and then moved to Harvard. And his was a nationally representative sample of Americans without an oversample of different racial and ethnic groups. Special feature, again, it was the first national study of Latinos and Asian Americans. We included multiple ethnic groups, including multiple languages. For Latinos, we focused on Cubans, Mexicans, Puerto Ricans, and other Latinos, and included for Asian Americans, Vietnamese, Chinese, and Filipinos, and other Asians. The languages were Spanish, Vietnamese, Cantonese, Mandarin, and Tagalog. So it's a very complex study. And one of the key things which we were interested in is to see how we could better understand immigration, since for Latinos and Asians there's a high proportion of immigrants within these samples. In previous attempts, whenever you have findings on Latinos and Asians, it was always difficult to compare whether they were actually similar findings or not, because the studies often use different kinds of research designs, sampling strategies, and questionnaires. In this study, we used the same sampling strategy and the same questionnaire that will allow us to make these kinds of comparisons. We also use a complex sampling design. We estimate that we went to about 40,000 households to find a sample of 2,500 Latinos and 2,100 Asian Americans. We had extensive screening for respondents. We focused on adults 18 and over, and we had a dual sampling strategy. We focused primarily on geographic areas where Latinos and Asians were 5% or more of the sample, and we got a smaller sample of Asians and Latinos where they were 5% or less of the sample. And these are a list of the types of mental disorders we focused on. Neurasthenia and Atakis are two more culturally specific kinds of problems that have been highlighted in the literature. Neurasthenia for Asian Americans, primarily Chinese, and Atakis for Latinos. And we asked these questions for all ethnic groups within the Latino and Asian American populations to see if it was unique to Asian Americans in terms of neurasthenia and Atakis for Latinos, to see if different racial and ethnic groups with endorse symptoms if they were not labeled as such. We also included questions and attempts to look at disorders around these less prevalent kinds of problems. This is the last category that we really didn't want to include because we knew it would be a low prevalence, and we thought it would consume a lot of time to include these questions, but it's one of those trade-offs to our funders, so we included these questions. And these are kind of the types of variables we included to help us examine some of the heterogeneity that I mentioned for Latino and Asian American population. In terms of context, before I show you some of the data, I think it's useful when we talk about immigration to have an understanding about rates in different countries. And this is the rate for lifetime prevalence of depression for the U.S. population. For Brazil, as an example, South Africa, Canada, Mexico, and South Korea, just as examples. And these are rates for 12-month depression for the U.S. and Brazil, South Africa, Mexico, Canada, and China. And as you can see, the U.S. has, in these kinds of comparison, higher rates than other countries for lifetime and current depression, which puts it into context when we talk about health disparities, that it's not always a good thing to try to strive to reduce the disparities between whites and other racial ethnic groups, that at times it may be useful to consider how we might maintain some of the rates, the lower rates for some health problems. This has come from the different epidemiological studies. This estimate comes from the National Comorbidity Study for whites. This comes from NLAAS for Latinos, have a rate of 10.8. The 8% for the black sample comes from the National Survey of American Lives. And for the Asian American study, was about 7%, which is quite lower than Latinos and whites. Oops. I'm sorry. I'm missing one category. But I think oh no, I'm sorry. I'm blind. Actually, this slide shows that the U.S. born had slightly higher rates than the overall Asian American category. When we examine these rates, one of the things that is striking is that Asian American U.S. born women had comparable rates for white women in terms of depression rates. They were about 18% lifetime, and a similar prevalence rate for 12-month depression. So just by when you look at just the category for Asian Americans, the rates are lower in general, but when you include gender, the rates are actually quite striking, where women, especially U.S.-born women, have comparable rates as white women. These are data to look at quality of care issues, and we looked at whether people had no treatment in the 12 months for depression, and about 40% of the white sample were identified as not having any treatment, and for the black sample it was nearly 60%, Latinos 64%, and Asian Americans 69%. And these data indicate that they, in effect, did not have access to any treatment for their depression over the past 12 months. We then identified whether people who had depression and had received treatment received adequate treatment. About 33% of whites received adequate treatment, 12% of blacks, 22% of Latinos, and only 13% of Asian Americans were identified as having adequate treatment for their depressive disorder. Yes. Sure.
As far as immigrant population, is that looked at separately? As far as like versus first generation, second generation?
Yeah, not for these analyses because we were tied up with the sample size issues. But when we did look at other analyses around access to services and not quality of care, the immigration-related variables were important. So those who were U.S.-born and were later generations tend to have greater access to mental health care. Yes?
I'm just wondering about the definition of adequate treatment.
Sure.
Subject self-report about or is it comparing what they got to some standard, objective standard of what it ought to be?
Yeah. That's a terrific question, and I knew it would come up today. And we spent a lot of time on this. We had consultations with a number of people, and Ken Wells from UCLA is also on the paper. And we did our best. Because of survey data, we're limited in the kinds of questions we had. But basically, this is what we came up with. We had a binary score of adequate treatment, assigning if a patient had 4 more specialty general health provider visits in a past year plus antidepressant use for 30 days or more, or if the patient had 8 or more specialty mental health provider visits in a past year. I believe this came from Phil Wang at UCLA, and especially used more in survey research data sets. So yeah, thank you for that question. So anyway, the basic findings from these analyses show that Blacks, Latinos, and Asians are less likely to receive mental health care for depression, and when they enter care, Blacks, Latinos, and Asians receive poor quality of care. And again, if you compare that to the findings from the 1970s, it's very similar. I would add, though, that the data that comes from the 1970s and these data are different. The data that comes from the 1970s relied primarily on management information system data, or people who actually came in for services. And these more recent data, especially from the National Comorbidity Study and our joint studies, come more from survey research. So you have a demonstration of both usage data as well as survey data from community samples that these findings seem relatively stable. So what has happened over the past 40 years? There's been an increase in community agencies serving Asian American communities, increase in a number of Asian American clinicians, especially those who are serving Asian American clients. There's been an increase in research capacity, probably not as much as I would like, especially, but there has been more research in Asian American communities. And there have been different kinds of models in community settings to serve Asian American communities. And there certainly has been a number of developments in treating depression over the past 40 years that are certainly appropriate for Asian American communities. So given all these developments, which are positive, why do we see the same kinds of funding? And actually we don't know, but we can take a guess. Some of the funding levels for research programs as well as intervention and services, especially to community agencies, certainly have fluctuated over the past 40 years. Hasn't been a stable source of funding, both from state, private, and federal agencies, to maintain the kinds of innovations that have been useful and have provided important evidence for their effectiveness. NIMH certainly over the past 10 years has decreased their attention to some of the social, cultural factors that are important in research and interventions. I can go more into that if you want. Over the past 5-10 years, there certainly has been a great burden in different states around providing funding for different community agencies, especially around mental health care. And certainly in California, I'm not entirely sure what the evidence shows in Washington State, but certainly in California, there is a turning away and a selectivity for serving people with different mental health problems, and the most severe are now served, and which leads to the greater problem that what happens to people who are in need of service does not provide service. Will it provide a greater burden to states in a very near future? And there's also been a lack of creativity, and I plead guilty to this, about how we think about services and research for different minority populations, especially for Asian Americans. I have a few suggestions. One is I think we need to take the notion of heterogeneity more seriously, and this reflects the last point around different trends, looking at the notion of super diversity and trying to better understand and better think through and develop better theories about how this diversity within different racial ethnic communities may impact health as well as interventions. And let me just provide a little data from our studies. These are data around the age of onset for different affective disorders, just for men, but the patterns for women are fairly similar. The 1.5 generation, the red line, refers to Asian American immigrants who came before the age of 12 years of age, and the yellow line, the 1.25 generation, or those Asian American immigrants who came as adolescents. And as you can see, there are very different patterns in terms of the age of onset. This comes from the NLAAS data. And for the immigrants who came as adolescents, there are two peaks around adolescence and middle adulthood for age of onset. And for the younger immigrants who came as younger children, it's more around young adulthood. This is a pattern for substance abuse, age of onset. And again, you find similar peaks, but more dramatic peak for the 1.25 generation about substance abuse at adolescence. This is another slide which looks at mental disorders in a little different way. These for immigrants who had a mental disorder, and shows you whether they had it prior to their arrival in the U.S. And this looks at generation in a different way. This is more around the age of immigration. This is for the 1.50 generation. And for the different disorders, this is for the 1.25 generation. And these next are immigrants who come as older adults, 18 to 30 for this bar. And this next one are immigrants who came as who are over 30 years of age. So you can see there's a dramatic difference, which makes sense that immigrants who come to the U.S. are not always developing their disorders when they come here, but some have these disorders prior to their arrival, which highlights the notion that there may be different strategies in reaching immigrants. And I think often we think of immigrants as one category, but there may be ways to think about developing strategies. It's clear that for immigrants who come as children and adolescents, there really is a pressing need over the next 10 years, I think, to develop more prevention programs to, slow the prevalence of mental disorders for this generation of Asian Americans. Just to highlight the notion of heterogeneity, again, it's looking at different risks depending on what kinds of variables we're looking at in Asian American communities. Age of immigration is an important distinction within Asian American and Latino communities. But there's also, we haven't really fully explored gender differences within Asian American communities and other kinds of variables that are important. I think we get locked in too much with the notion of just looking at ethnicity. And again, interventions will vary by age, and prevention will be critical for Asian American communities. The second point is related to how we understand how research is disseminated and actually used within communities and also understood by individuals. I think we have a great idea as researchers on how to develop research projects and interventions and test them. But we don't have a great understanding about how that evidence actually filters to individuals and how that individual takes up that research evidence and uses that in their everyday life. And I think we need to spend more time and resources and research to better understand the mechanisms by which people and communities actually take up this kind of research and understanding about mental health problem. And this third point relates to the notion of how interventions are developed or even research are developed. We often take interventions developed in the dominant culture, usually white mainstream middle class cultures, and then we assess their success or effectiveness within that community, and then we try to translate or to develop interventions, similar interventions within different racial and ethnic minority communities. And it may be time to make a more and a concerted effort to look at research and interventions that have been developed in other cultures, test it out within those cultures, and then testing their applicability to the more mainstream. And I think this kind of give and take might lend itself to better kind of cultural, better sense about the cultural responsiveness of different mental health kind programs. I used a lot of movie references, and so let me end this portion of the talk with another movie reference. This is a scene from Jaws where they are on their little boat and they're searching for the great white shark. And this is a time when they get their first glimpse of that white shark. And they're looking at it, and it's a much bigger shark than they had imagined. And I forgot the character's name, but turned to each other and they said, we need a bigger boat. And I think that's the way I would see the future of looking at research in Asian American communities, or on examining the whole notion of cultural responsiveness, or how we develop interventions that are appropriate for different kinds of cultures, is that we need to think of encompassing more of the different disciplinary perspectives and how we incorporate communities as well as academia. We haven't done a great job of it, at least from my perspective. And I think by having a larger boat, we certainly can incorporate the many talents that we have from these different disciplines and different communities. So I'll end there, but certainly entertain any questions or comments you might have. Thank you.
That's
Yes.
a lovely presentation. I have two
into a little bit. In U.S. culture, at least, women tend to have twice the rates of depression than men. Maybe men are expressing it somewhat differently. Did you see that emerging in the Asian American or the Asian studies that you did in terms of differential gender rates?
Yes, we did for both the Latinos and Asians. The U.S.-born women had almost actually 2 to 1 the rate of Asian American men, and this is true for the U.S.-born. It's kind of a U.S.-born gender interaction. The U.S.-born men and women show that same pattern, but we did not find the same pattern for immigrant men and women. In fact, the immigrant women had slightly lower rates than the immigrant men. Interesting. Yeah. We're not entirely sure what that means, but it certainly is consistent with a number of studies and writings about immigrant men not finding the kinds of rewards they may have had in their home country. That is, immigrant women may have a greater capacity to find jobs, and which may change the gender dynamics within the household. So that's speculation.
Interesting. My other question relates to your comment about access to care and at least patients finding themselves in care.
Mm-hmm.
Your survey included neurasthenia, which
Correct.
is clearly an acknowledgement that in some cultures, China,
Mm-hmm.
depression may not be perceived or experienced or culturally labeled the same way. I'm curious if you could talk about the interplay between actual access to care versus accessing care in terms of the cultural dynamics that may either promote or inhibit people from going to seek care, even if it were available. What's the...
Yeah, we did some analyses by geography where we could identify. We can't publish it because of some confidentiality arrangements, but we could identify geographic areas where we could identify that there were different community resources available to Asian Americans, so ethnic-specific kinds of clinics and so on. And that actually did not seem to, did not vary much in terms of Asian American access to care. That is, Asian Americans in communities where we could identify there were resources were just as likely not to use services as Asian Americans in communities where you had resources. And I think access is, at this point, one of the critical problems we haven't resolved for Asian American and Latino communities. You even hear it from service providers who work in ethnic-specific clinics, is that they're not coming in at the rates that we think. And given the kind of financial crises that a number of states are doing, even if they were to come in, I'm not sure they could get served. So it's really this double-edged sword is, can you actually serve the Asian American and Latino communities given the kind of resources that you don't have? So,
Yeah, and of course the differences in stigma are quite
Sure.
prominent as
Yeah.
well that seem to play,
Yeah.
must be play at play here as well.
I think there have been a number of discussions about whether we just need to radically think about how we achieve this outreach. And I believe Ricardo Munoz has been doing a number of, I forget the correct term, but he's using a number of online internet kinds of means to reach clients. And I think he's also experimenting with Asian Americans. And it'd be interesting to see how that plays out in terms of accessing those populations. We actually have done some observational studies in communities, and we've gone to some community health clinics and mental health clinics that have offered services for Asian Americans, but they actually have the same kinds of issues that other clinics have. They have long waiting periods. They don't access services fairly quickly, so that people leave or may not come back again. It's this delicate balance about how we resolve these kind of issues, especially given these budgetary times. Yes.
Could you briefly discuss any lessons you learned in your study of the culturally specific syndromes you looked at?
Yeah, I wish we had spent more time on that. The study actually met with the psychology interns yesterday, and we talked about, I gave them the inside scoop about how the study was actually conducted and all the problems we encountered, and including all these dances we had to do around the budget. And we had a short time period to pull the questionnaire together, and we had this constant battle with NIMH about what they wanted versus what we wanted. And the opportunity to include neurasthenia and atakas came about at the last moment, and we struggled to find appropriate questions for that. We had Peter Guarnaccia, who is an expert in atakas, and so we used some of the questions that he was familiar with in our study. And neurasthenia, we used, I think the World Health Organization had a set of questions, and we actually haven't had a chance to thoroughly examine those items yet. But preliminary analyses show that it's not necessarily related to the types of services you seek out, at least the preliminary analysis. That is, you would think that people with neurasthenia would be more likely to go to a primary care if they had a problem, but that doesn't seem to play out. They're just not going into care. Yes, Joe.
I was wondering if you had any suggestions for clinical researchers who were either seeking to develop or to adapt psychosocial treatments, cognitive behavioral therapies, for example, for the Asian American population.
You know, that's not my forte, unfortunately. But I know there are a number of researchers, and I work with some of them, Nolan Zane and Gordon Nagayama Hall, who's a graduate from UW. Actually, both Nolan Zane and Gordy are graduates of UW. And I know they've been developing a number of interventions that have been, that they've adapted. And they probably would be the better source rather than a sociologist trying to comment. Which might be a big problem.
I just if you had any insights. Thank you.
Yes.
Medicaid eligibility is one of the tickets into community mental health in general.
Mm-hmm.
And I wondered if you found that folks who were, for whatever reason, not eligible for Medicaid based on being recent immigrants, or if that impacted access to care, just the financial piece of accessing care.
We did a little bit. The sample sizes around those kind of issues were quite small for us to really a thorough analysis. But you make a good point that folks on Medicaid were more likely to access services. But we haven't looked at the quality of care issue because we can't actually do that with a small sample size. But yeah, the funding did at least, was associated with access to care. Yes.
Did you guys, I don't know, you'd have to do it over many decades, but you look at the different waves of the immigrants, you know, the initial Filipino, Japanese, Chinese, Koreans, and then the Southeast Asians, and then, you know, as people came here, developed their kind of middle class ways, and then the next wave came. When we look at the 70s, where it would have probably been Vietnamese, and that group that came in, and then now, where you have Pacific Islanders and all these other, trying to figure out how you're going to put those kind of genetic pools together is maddening. Just to think of how you would treat these kind of variants of one genetic pool maybe. It's not all the same.
Yeah. Yeah, there were definitely different populations and kind of the genetic, biological, as well as the social, cultural factors that are certainly different over the past 40, 50 years. But it is still striking that we find the same kinds of issues, and we really haven't found any great solutions to resolving the access and quality. That is, we're not able to reach out and provide the kind of services that some, especially Asian Americans, as well as other racial ethnic minority groups, may need given their mental health problems. And that is still a major problem that is unresolved. Yes, sir.
The extraordinary differences in rates of depression
Yes.
between the United States and less developed countries, for
Yes.
example, in Africa. I know this is a huge subject, but how real do you think that is versus being attributable to a measurement error or a difficulty in capturing what is depression in these cultures?
I think this is kind of a sociological wishy-washy answer. It's probably somewhere in between. I think it's real in the sense of maybe the differences. I think if we had the perfect measure, we'd probably still find differences between the U.S. and other countries. Mainly because of the way Westerners, especially U.S., may express their distress in more emotional kinds of idioms. But I also think, which you make a great point, is that there are a number of measurement issues that we really haven't resolved. I mean, we're using the same kinds of instruments that have been tested in different cultures and countries, but it's still using the same questions. We haven't taken the opposite approach that I mentioned about trying to access problems more from an indigenous point of view, and then going back and developing the questions and seeing whether if those kind of indigenous views of mental health would derive similar kinds of responses in the U.S., kind of working it from a different angle. I think there are not only issues around the types of questions, but there's also questions about, I guess, the standards or how we develop the categories of things like depression, whether we really need all those kinds of symptoms to reach this high criteria that seems important in the U.S. but may not be important in other countries. So I know there's a movement to move past kind of these diagnostic into more, to develop other kinds of measures, whether it be more continuum, other kinds of distress. But I think the jury is still out as to how much of it is a real difference versus measurement versus an expression.
And if it is real, what can we learn about how we make people depressed here?
That's right. That's right.
What are they doing?
Yeah, it raises this great question about health disparities and how we think of it. Even if we move past depression and look into coronary problems that the U.S. has higher rates than other countries, and certainly the goal should not be one of reducing the difference between whites and other racial ethnic groups, but it might be one of trying to move the standards to a higher level of what a healthy lifestyle or healthy rate should be. And I think we sometimes get trapped into this way of thinking about some issues, and we don't take a step back of what does it actually mean when we talk about disparities and what we want to achieve.
So on that mindfulness note, I think perhaps we should stop and thank Dr. Takeuchi for a wonderful presentation.